Very excited to be here today to talk about some of the work that we have been doing in Matrix 7. And I really want to highlight, in particular, Dr. Fiona Schulte and Dr. Leandro Desjardins, because they'll be talking about a lot of the work that they have led over the last couple of years within our matrix. So first, I don't think it'll be a shocker to say that family distress in pediatric oncology is relatively common. Speaking of families, we could be thinking about the parents of children with cancer, the child themselves, siblings, really any family member. We've done some work to actually show that in the parents of children with cancer, this distress can be clinically significant and can persist over the first year of the child's cancer diagnosis. And we also know that distress is associated with a host of negative child and family outcomes, so reduced family functioning, reduced treatment adherence, and others. And of course, identification of this distress absolutely critical to be able to offer families the proper psychosocial support that they need. And these screenshots here on the far side of the slide are in acknowledgement of the pediatric psychosocial standards of care, which were developed now in 2015, but really were put forth to improve the holistic care that children with cancer and their families get. So a focus on the medical care, but also on the psychosocial side of things as well. And you can see the top listed standard there is the assessment of psychosocial needs, and that is what I'll focus on in the next few minutes. So to start, Leandra within our group had led some work looking at how well these psychosocial standards of care are implemented across the 16 pediatric cancer care sites in Canada. And to do so, she used a landscape review surveying each of the sites. She did hear back from each and every site with regard to if and how they are implementing the psychosocial standards at their center. And so in particular reference to psychosocial screening, what we do see happily is that 87% of the respondents to Leandra's survey said that they usually or always assess psychosocial needs in their families. But when we dug down to look at how that assessment was happening, it was most commonly happening through informal discussion or through interview. So really then limiting our capacity to systematically determine how distress might be presenting within a family and then between families as well. Some of the barriers identified included uncertainty around which tools to choose to do this kind of screening, challenges related to workflow integration, and uncertainty as well around implementation and sustainability of these kind of screening protocols into cancer care programs. So at the same time that Leandra was doing that work, our group in Matrix 7 was really tasked with coming up with some project ideas that could advance ACCESS's goal of improving the psychosocial health of kids with cancer in Canada. And so when we set out to do that, we really wanted to make sure that our projects were grounded in what the community really wanted. So how did we do that? We used kind of two streams of evidence to kind of push us forward in project direction. The first was a national priority setting project that I had done with children with cancer, their families, and clinicians that really showed that family psychosocial health is a key research priority of the community. And then the second was two ACCESS town hall meetings that we held. We had a good number of community members attend each of those meetings. And from those meetings really learned that cancer-related stress is a big issue for families, again, maybe unsurprisingly, and that systematic assessment of family psychosocial needs is required. And so with those as our marching orders, we set out to implement context-sensitive family psychosocial screening into routine practice. Future goal to get this done across the country, but we're starting more locally with 4 centers, and I'll talk about that in a few moments. But want to draw attention to the fact that context sensitive is mentioned here. So we recognize, of course, that the different centers have different patient populations, different complements of clinicians, different access to supports. And so we recognize then that what psychosocial screening shows up like at a given site will differ kind of site to site. But really our goal is to systematize screening however it might look at each site. So as a first step towards that work, we led 2 scoping reviews. I should say Dr. Fiona Schulte led 2 scoping reviews looking at identifying appropriate psychosocial tools for this process. And so one of those reviews focused on tools that we might use to screen for distress in the parents of children with cancer. And then the other looking at tools we might use to screen for distress in the child themselves. Fiona went through a wealth of evidence and then did an assessment of tools that were identified based on the strength of their evidence in the literature, their psychometric properties, were they valid and reliable, and then also their clinical utilities. So this included things like, is there a cost associated with using the tool in routine practice? Is it available in multiple languages? And does it include actionable cut points for follow-up and support? And so the first paper from these 2 scoping reviews is now submitted. And we are hoping that the results of each of these scoping reviews can really help to inform the way that sites across the country implement psychosocial screening at their site by maybe providing them with, a bundle of tools or a single tool that they might use. And so that kind of started to prepare us for how we might actually do the implementation of psychosocial screening. We wanted to start first with a single site, so started here at SickKids. And this work led by Dr. Renee Potnischer, who had a number of conversations with people across SickKids to kind of look at, from a context-sensitive perspective, what psychosocial screening might look like here. And it started to really look like the appropriate tool to use here would be the distress thermometer, which was identified through Fiona's scoping reviews as well as a good tool to use. And then that screening would probably show up from a modality point of view through EPIC. So to get us started in working in that direction, Renee asked the question, how can EPIC integrated psychosocial screening be best implemented into practice? And she led a qualitative study interviewing 10 parents and 10 clinicians here at SickKids to answer that question. So what did Renee hear? She heard a number of things from both parents and clinicians about how we might get this work done. The first from parents really showed that that screening needs to be simple for busy families, of course, and integrated into existing systems, as opposed to using a new system to do this work or using kind of paper-based methods. So MyChart, families were very familiar with using that and wanted to continue to use that as they moved ahead in the screening process. We learned a little bit about emotional readiness and timing for screening as well. So families telling us probably not the best time to initiate screening right around the child's diagnosis, maybe kind of a month out or several weeks out. We might be ready to start screening then. They let us know that screening must trigger meaningful action and support for the family. And that human relationships will remain central to the implementation. So they didn't want this kind of EPIC-based screening to get in the way of the conversations that they were already having with their clinicians. From the clinician side, we heard that psychosocial needs are recognized, but maybe not systematically. So families are noticed to have needs, but we're not doing it, again, in a regular fashion. Integration into clinical workflows, it will be integral to making this a success. That screening must be accessible across multiple languages and cultural contexts. So Renee is working with the distress thermometer as a tool to do this screening, and that tool is luckily available across multiple languages. And then also, and dovetailing really with what parents said about meaningful action and support, that clear response pathways, engaging multidisciplinary providers are really going to be needed for positive screens. So presenting just one quote from a clinician who was involved in the study that says, I think that the people that will benefit the most are probably people that wouldn't speak to us as often as they truly need to. A lot of people don't want to ask for help themselves. They're here for their child. So again, making that point that clinicians are recognizing that there's psychosocial needs within the families that they care for, but maybe because we're not routinely assessing that psychosocial need profile, we're missing out on certain families who could benefit from our supports. So from Renee's work, again, I summarized just a few of the very high level points that Renee has been able to pull out. I think we're still going through the data, looking for nuances regarding screening that will hopefully bring it to life here at SickKids. But what Renee has initially found is that it has to be easy for parents to complete, or it won't work. It needs to be seamlessly integrated into workflows. We really need real-time identification of distress, and that clear follow-up pathways and triage algorithms are going to be needed to support clinicians in doing the work of caring for families who do screen positive for distress. And this is a screenshot here. I don't know that Renee even knows that I took this. She made a presentation last week and I snapped a quick screen grab, but this is an algorithm that she has developed to show that how we will action care to families who screen as having low, medium, or high distress. So what are we going to do next? We are going to pilot implementation of routine psychosocial screening at 4 centers. We're starting out at Alberta Children's, here at SickKids, CHEO, and also Saint-Justin. And we're going to learn from those 4 diverse centers what are the barriers and facilitators to psychosocial screening implementation into routine practice, and hopefully take those lessons forward to scale up to all of the sites where children receive cancer care across the country. So with that, really want to thank ACCESS and the members of Matrix 7, as well as all of those people who were involved in the study, particularly David Brownstone and the psychosocial team here at SickKids, who have really worked with us in lockstep to get a lot of this work done. And I also note that I don't have Dr. Adam Yan here listed, and he has been really helpful in thinking about how we can make this happen through EPIC. So thank you.
Great talk. So the floor is open for questions.
Well, thank you for doing studies like this. As a parent who had a child that was sick, this is has been a long time coming. The second thing I wanted to say is you mentioned emotional readiness and sort of the safety based on human relationships. Has there been any studies to date that have looked at the use of people with lived experience as a facilitator to those conversations for that human connection and the emotional readiness?
So would you...
I didn't mean to put you on the spot. I was just wondering, because I know that as somebody with lived experience, the conversation often with healthcare providers in that situation would be strained for numerous reasons. There's fear of further, testing on children, just sort of the gatekeeping that happens. But when people with lived experience are included in those conversations, I often found for myself that there was already that barrier of the emotional, there was already the facilitator of emotional connection. And then there was also the feelings of like commonality and understanding that I could say things that wouldn't be maybe misconstrued, or if there was other context that could have been misinterpreted, that there was the safety there to have the conversation. So I'm wondering if that's ever been a consideration of utilizing people with lived experience within those spaces for the facilitation of the psychosocial screening.
I think it's a really good point. We did not explore it during our interviews with clinicians and families, but I can say in the literature, there is a good amount of evidence now to show that kind of peer support for families from people, exactly as you say, who have walked that path, is found by families to be very helpful in sort of supporting their engagement in care and also just their psychosocial health more generally. As I say, we've not explored it, but I think certainly considerations there related to how it would show up in practice, I think are probably important to understand a little bit more. Who would this person be? What privacy issues do we need to consider? How would they kind of be at the clinic routinely, these types of things. But not to say it shouldn't be explored just because it's difficult to do so.
Yeah, I just thought it's knowing relationships that have happened with like community organizations within the hospital, and just even to this day still having connections with those organizations and the conversations that happen. There's an element of safety that
Yes.
can be negotiated in different pathways with parents who have walked that same journey. And there was just a note. And just even the willingness of PWLEs to be included within those spaces as well. And I will say within ACCESS for myself, having these opportunities to see that engagement or have my feedback implemented into some of the projects, that has created many opportunities for me also to heal sort of some of these things that have happened along the way. So it allows for another element of looking at the psychosocial supports and how they can facilitate like meaningful engagement after a child or a family has gone through this.
Point well taken. And as you were speaking, I was also thinking about kind of at Sick Kids, how we intend kind of the supports to show up if a family does screen as having distress. And one of the avenues that we've really started to investigate, really led by Renee and also David Brownstone, is Gilda's Club. So putting families in contact with peer support and with other families that they can kind of talk through a lot of these issues in. So that wouldn't show up kind of at the actual sort of assessment side of things or at the moment of psychosocial assessment, but could show up actually downstream as a support mechanism for families.
Last thing, I'm sorry. I just wanted, because I'm absolutely blown away. Like personally, I'm actually sitting beside, and I know there's a bunch of other moms and family members, but I'm sitting beside three other moms that have gone back to school to get their education in social work and to work within this community, and to know that this exists and there's families out there that have opened up and in ways that I couldn't have even imagined 10 years ago when my daughter was diagnosed. I'm in awe of all of the parents, but just to be sitting beside two other moms that have done this, I think it's really a space to be looked at because there's so much within it that we don't.